I take this opportunity to welcome you all on behalf of Hetero Healthcare, and I am Sachidanand Yadav, working as a divisional manager for Hillian Division. First of all, thanking for joining us today to discuss on Cariprazine basics and its case-based approach by Dr. Vishal Chandra sir. As you know about Hetero Healthcare, we have the largest R&D providing 360-degree solutions. Hetero has more than 25 years of excellence in multiple therapies and present in more than 126 plus countries worldwide. Hetero has more than 200 products across therapies such as HIV, AIDS, oncology, cardiovascular, and neurology. And we are having 4 biosimilar products also in market. 36 plus states of art of manufacturing facilities, pioneering in quality and innovation. So today we have Dr. Vishal Chandra sir as a speaker. Just to introduce sir, sir is currently working as a HOD Psychiatry Department for Fortis Healthcare, New Delhi. And sir has done his MBBS, BPM and DNB Psychiatry from the KMC Manipal. Sir has a vast experience in psychiatry. Sir has worked as a senior consultant psychiatrist from 2012 to 2017, Metro Hospital Heart Institute in New Delhi. Previous to that, he has worked as a psychiatrist from 2019 to 12 in New Delhi, Vimans Hospital. And sir has a special interest in DA Dixon and other psychiatric therapy areas. And talking about the moderator, today we have moderator for the session, Dr. Manushree Gupta, who is currently working as a professor in Vardhaman Mahabir Medical College, Safdarjung Hospital. And sir has done his MBBS from Era Medical College, Lucknow, and his MD Psychiatry from Amritsar Government Medical College. Just to starting the session, thank you, sir, for joining. Over to you, Dr. Vishal Chandra, sir.
Then maybe Dr. Manushree wanted to say a few words before I start. Anything you want to add, Dr. Manushree, before I make a presentation?
I just have good thoughts about you, sir. And it's always, I look forward to chairing a session or maybe being a co-speaker with you. So it's always a learning experience as well. And yes, certainly a pleasurable one. But yes, coming back to the molecule that we're discussing today, I think it's Cariprazine. And Dr. Vishal Chandra has a lot of experience in clinical research, as I know from with my personal interactions with him. So he was one of the earliest researchers for vortioxetine, if I am correct, and he has carried out a number of clinical trials while being at Manipal Institute of Medical Sciences, and later on when he was senior resident at UCMS. So I can't think of any other person who would be apt to talk about this Cariprazine. And yes, Hetero is bringing about this molecule in the neuroscience division, I believe. And we have all had experience with Cariprazine, and it's a considerable one now. So without any further delay, I would request Dr. Vishal Chandra to enlighten us, please. Thank you.
Thank you so much, Manushree. It's a pleasure to be here. I think this is their first trial, so I think they're still going through those teething issues. So today we'll be talking about Cariprazine, and I've been told around 50 to 70 psychiatrists joining us online, watching the live stream. So for all of them, more than presentation, I would like that if there are any questions, or more importantly, if people have any experiences, please do share in the comments, and one of the Hetero people will pick up and we'll try to share that here live. And I think that will be much more enriching and fruitful for us for today. So coming to the presentation, as you know, schizophrenia is a very complex disorder. It has all different kinds of symptoms, whether you have positive symptoms, negative symptoms, or cognitive symptoms. Maybe in the initial drugs of schizophrenia worked on positive symptoms very well, but we're still looking for good answers for both negative and cognitive symptoms, and still there is scope for improvement of positive symptoms, because in certain patients, resistant delusions and persistent auditory hallucinations are there despite all kinds of medicine. So there is still scope despite us understanding and defining the signs and symptoms of schizophrenia. In fact, if you look at psychiatry, was built up on basically two disorders. One is schizophrenia and other is bipolar. That's how the psychiatry got developed over time. All other disorders came after that. So these were the two very important uh, disorders, and the molecule I'm going to talk about works on both of them. So what are the symptoms of bipolar disorder? Manic symptoms, as you all know, racing thoughts, inflated self-esteem, and depressive symptoms, low mood, lack of concentration, loss of interest, and sleep and appetite issues. The first generation antipsychotics, as you all know, chlorpromazine, very sedating, flupentixol, haloperidol, trifluperazine. So all those drugs were very useful for taking care of the positive symptoms of schizophrenia initially. But when we realized that, okay, the symptoms are getting better, but patient not doing anything, patient is sitting at one place, then people define negative symptoms of schizophrenia. And later the research over the decades have found there are also cognitive symptoms, which the initial slide didn't mention. Besides positive and negative symptoms and cognitive symptoms, there are also mood issues in these patients also. It's not just because they have schizophrenia, they cannot have mood symptoms. So they have mood symptoms also. So all those typical antipsychotics are very good in taking care of the so-called positive symptoms of schizophrenia, but not so good with the negative or with the cognitive or mood symptoms. Then, with the research, second generation antipsychotics came up because we're looking for newer and better molecules. We understand that just not dopamine hypothesis of schizophrenia, we realize there are more receptors, more neurotransmitters involved in causation of schizophrenia and also for bipolar. They were looking for better, newer drugs. Also, the typical antipsychotics have the problem with EPS, the dystonias, the tardive dyskinesias. So how do we, those are very debilitating conditions. So how do you work with them and how to help the patient despite and without causing such issues? So that's where typical antipsychotics came in. Risperidone came in, olanzapine, quetiapine, clozapine, and enzalutamide, aripiprazole, haloperidol, and now we have cariprazine also. So these are the atypical. These were called second generation. So those called first generation FGAs. These were called second generation antipsychotics. But when aripiprazole came, there was something interesting about aripiprazole. Aripiprazole is not an antagonist, but more of a partial agonist. And I still remember it was launched a lot of fanfare as being the very good treatment for mania initially. But because of the partial agonism, it was not a very effective treatment for the acute mania. So it did not work very well as a molecule. But later people realized the value of it on a long term. So it became more of a disease modifying agent in the sense that it will not block the receptors completely, but also not leave them open for patients to suffer from hallucinations or delusions or other symptoms. So from there, this thought came that maybe these second generation are not all second generation. Some of them could be called as third generation antipsychotics. And in this table, as you can see, we have first generation antipsychotics, which are basically dopamine receptor antagonists, mainly targeting D2 receptors. So phenothiazines, butyrophenones like haloperidol, phenothiazines like chlorpromazine, thiazanthines like clopentixol, dihydroindolols like molindol, and dibenzapines like loxapine. Then second generation, they have not just working on D2 receptors or dopamine receptors, also targeting 5-HT2A or serotonin receptors, which was only thought to work only for depression before, but now we know it's much more than just for depression. And so the name of the drugs here are risperidone, paliperidone, ziprasidone, lurasidone, clozapine, olanzapine, and quetiapine. Now, as I was saying, new coinage, and some it may be new for some people, TGAs or third generation antipsychotics. These are D2 partial agonists, and depending on dopamine concentration, can have antagonistic effects on dopamine receptors. So the three molecules in this are group are aripiprazole, which was earlier called SGA. Now we're calling it some in TGAs, brexpiprazole, and cariprazine, which we are talking about today. What are the side effects of antipsychotics? Which are which drugs are going to cause more? So weight gain and diabetes, those are very, very important side effects of these drugs. Clozapine can cause a lot of weight gain. Olanzapine also, quetiapine, risperidone. So the least with ziprasidone and aripiprazole, but most with clozapine and olanzapine. This is the descending order. If we go to movement effects or the side effects because of the dopamine blocking, the risperidone, olanzapine, quetiapine, ziprasidone. Clozapine causes the least, aripiprazole the second least, and then other drugs in between. So maximum is caused by risperidone. Here we're looking at side effects of atypical antipsychotic, not typical. Otherwise, so though second generation came with a lot of fanfare thinking that they will not cause any EPS, lo and behold, they do cause EPS in many conditions, and risperidone being one of the oldest second generation antipsychotic, which were actually that time there was no classification of first and second. That causes the most, and as the molecules became better, this EPS or the dopamine blocking reduced, so were the side effects reduced. Sedation again, or low energy, sleepiness caused because medication. Clozapine, as you know, is very, very sedating, followed by olanzapine and quetiapine. We, in fact, a lot of us use quetiapine for sedation in our patients because we don't use chlorpromazine anymore, most of us. But the least again sedative is aripiprazole, then ziprasidone and risperidone. Decreased sex drive and again, this is one of the important side effects of the medicine, which can lead to patient. All of them can make patient leave the medication, reduces the compliance with the treatment. So decreased sex drive and function, missed periods, discharge from so hyperlactinemia, lactation, all those issues which can happen with the drugs, reduced libido. So risperidone again, one of the leading causes of these side effects, followed by olanzapine, quetiapine, and clozapine and ziprasidone are the least. Now, where do we put cariprazine in the therapy? So cariprazine has been found, this is all US data, was found to be most prescribed to patients presenting with first episode of psychosis. As younger patients are actually much more, because they have very important studies and career in front of them, then a very initial and crucial stage of their lives. So they found that this is where cariprazine is a very good agent, and we look at why it's a good agent in the following slide. And also because cariprazine doesn't cause a lot of side effects. So we'll look at those in the coming slides. Where is it approved? So in 2015, if I remember, FDA approved cariprazine for the treatment of schizophrenia. Later, it was also approved for acute treatment of acute mania or mixed episode associated with bipolar depression. And latest, which is not mentioned in this slide, it is also approved as an adjunct treatment in unipolar depression. So not just schizophrenia, but also in bipolar. So it's a pretty broad spectrum antipsychotic. What are the dosages available for this drug? As you all know, the doses available are 1.5 and 3 milligram for this brand we're talking today. And in schizophrenia, the starting doses, and for bipolar mania also, the starting doses 1.5 milligram per day and can go up to 6 milligrams per day. Also for unipolar depression, again, which is not mentioned here, you can use up to 3 milligram per day in a unipolar depression as an adjunct treatment. So what is the mode of action of this drug? Cariprazine is a partial agonist at D2 and D3 receptors with significantly greater affinity for D3 receptors. It exerts partial agonism at 5-HT1A receptors, antagonism at 5-HT2A and 5-HT2B receptors, and minimal antagonism at 5-HT2C, 5-HT7, and H1 receptors. So this is a cartoon representing the where or what are receptors. So you see, look at D2, D3. So PA for partial agonist, and D3 and 5HT2A, and also 5HT1A. It has some antidepressant action also because of 5HT1A action. If you look at the D3 receptor, what is the role of dopamine D3 receptors? So antagonism and partial agonism of dopamine D3 receptor can mediate movement improvements in social interaction, anti-anhedonic, and pro-cognitive effects. So D3 receptors are not just for this thing, but it has its role in social interactions, which you see these patients of schizophrenia, in the negative symptoms, you see they don't want to talk to anyone, they have abulia, elogia, so lack of socialism, anhedonia, all that happens. So here you see D3 receptors having some role there. D3 antagonism in the midbrain can increase dopamine neurotransmission to the prefrontal cortex in nuclear accumbens, reversing the hypodopaminergic functioning, which has been linked to negative symptoms and mood deficits. So if you see different areas of the brain in schizophrenia have different dopamine levels. So when you block dopamine throughout, it causes hypodopamine levels in the frontal area, which is very important for executive functioning. So here, this drug is theoretically trying to reverse that by working on D3. Also, increase in dopamine in the prefrontal cortex can activate D1 receptor, which in turn could further mediate improvements in cognition and negative symptoms. So this drug is not working on D1, but through a cascading effect, it can help also activate D1 receptors through D3. So D3 receptors are also known to increase in acetylcholine, in the prefrontal cortex and regulate glutamate. So it's not just dopamine, it's also helping with glutamate and acetylcholine also, which also helps with the cognition. And this is again a diagram showing all that, which I was talking before. So if you look at the affinity for receptor types for various atypical antipsychotics, aripiprazole, look at the D1 receptor, D2 receptor, 5HT2, alpha-1, and muscarinic receptor and histaminic receptors. And the more plus, the higher the affinity, right? So let's look at aripiprazole, which is one of the favorite molecules these days. And again, it's a wide spectrum antipsychotic, which is given in bipolar, unipolar, OCD, schizophrenia, obviously. And you look at it has a higher D2 affinity than D1. It has 5HT2 affinity also. Alpha-1 affinity, nothing muscular, but histaminic also. Asinapine we don't use anymore. Cariprazine and brexpiprazole. Brexpiprazole we don't have right now, but cariprazine is the molecule for today. It has a good D2, 5HT2, alpha-1, and histaminic actions. And these are the other, you look at the other receptors also for olanzapine, lurasidone, iloperidone. Again, we don't use iloperidone much, clozapine. Lurasidone also came with a lot of fanfare, and it'll be interesting to know people's thought about lurasidone in the comments after my talk. I'd like to know how they use it. And people use riprosidone these days that people have forgot. I have also used it in some patients, but not much. But again, it will be interesting. So most of the people I see using, at least in Delhi, is aripiprazole, cariprazine for sure, clozapine a lot, olanzapine, quetiapine, and risperidone. But we don't use paliperidone that much, and ziprasidone much, and lurasidone. So we have a bigger armamentarium, but we don't use them. So let's look at the, again, mechanism of action of cariprazine. Look at the D3 partial agonist, improvement of positive, negative, and depressive symptoms. This is the why it's supposed to stand out, and we'll discuss, does it stand out or no? And because of this partial agonism of D3, it's D3, binding to D3 is much better than for D2, and it's like partial agonism is almost 10-fold higher affinity for D3 than D2. And this is why It may not be very strong antipsychotic in traditional sense, but it's a very good antipsychotic to theoretically again to help with the negative and depressive symptoms and also exerting some kind of pro-cognitive effect on the brain. Again, so we know D2 helps with the positive symptoms, and 5-HT1 a partial agonism helps with the improvement in negative and depressive symptoms. Because of this 5-2 antagonist, low risk of acceptable side effects. Because of 5-2 antagonist, improvement in depressive symptoms and pro-cognitive effects again. 5-2C antagonism, improvement in depressive symptoms again. So because of this antagonist, this unique design of this molecule, it helps with lesser EPS and improvement in positive symptoms, negative symptoms, depressive symptoms, and also exerting some cognitive effect on pro-cognitive effect on this. That means improving their cognition. Let's look at the pharmacokinetics of cariprazine. This is the amount of drug in the blood. On the y-axis, on the x-axis, you have time. So drug is taken, and this area under the curve is overall drug exposure. Oral bioavailability is 52%. There's a very high protein binding of 97%. Cmax, there's the breach, the peak plasma concentration happens in 3 to 6 hours. The steady state concentration attained after 3 weeks. Half-life of drug, it goes T-half. So it has a half-life of 2 to 4 days. So it's a very long-acting drug. It has two main metabolites, desmethylcariprazine, D-car, and di-desmethylcariprazine, DD-car. So D-car and DD-car, these two cars drive a long way. So DD-car has a half-life of 1 to 3 weeks. So it stays in blood for a longer time. Okay, I'm getting some mess. Okay, I will try and answer these questions. I see some questions in the chat.
So, sir, how do you suggest? Can we do it parallelly, or we'll take it towards the end of the session?
I think towards the end of the session will be better. Let me
right, sir.
So that
right,
Dr. Manu can also join in and weigh in with his ideas, right? So it's not just me talking.
Absolutely. So we'll take it in the end.
Yeah. So, but you keep pulling in questions. That is good. Keep pulling the question. No problem.
Sure, sir. Sure.
And so it is metabolized by CYP3A4 and to a small extent by CYP2D6. So what is important here, remember, once a day dosing is enough because it is very long half-life, and maybe in some sensitive patient, theoretically, you can even use it alternate days. Okay. So what are the key advantages of this drug? It's less weight gain, no significant increase in QTC, once a daily dosing, absence of prolonged titration period, and minimal anticholinergic, metabolic, and prolactin-related side effects. These are so more of a safer drug that effective in negative symptoms where many antipsychotics fail. That's the advantage theoretically here. Let's look at few clinical trials. So this is a weak point with this drug. Let me put it across initially. It doesn't have too many drug trials because it's still a new drug that way. It has few major trials which helped it got the approval from FDA, but there's not much here. What did this drug says? So it was, so let's look at, 1 second. Cariprazine has a high, due to its high affinity to D3 receptors. So if you look at this, this trial, this is MDD's major depressive disorder, mean change from baseline. If you look, the patient showed improvement in MADRS scale and in Sheehan disability scale, SDS, I think is Sheehan disability scale, total scores compared to placebo, over a period of 16 weeks. It continuously showed improvement compared to placebo. And this other track, MADRS remission rates were improved with cariprazine versus placebo. So it showed significant reduction in MADRS scores. It is a broad spectrum antipsychotic. This article by Itzwan Lazowski This is published in 2021. It is showing that it is a broad spectrum, and cariprazine is shown broad spectrum because, as I was mentioning before, because of it, the way it works on various receptors, both serotonin and dopaminic receptors, and more affinity for D3. It was found to be generally safe and well-tolerated in trials in drugs with acute and both long-term exposure to this drug. Cariprazine acute exacerbation of schizophrenia, a fixed dose phase 3 randomized double-blind control trial. This is by Suresh Durgam. And this trial found that it was a multinational randomized double-blind trial, randomized for 6 weeks. There were 4 groups: placebo group, cariprazine 3 mg group, 6 mg group, and ariprazole 10 mg group. The primary and secondary efficacy parameters were mean change from baseline to week 6 in PAN score and CGI-S scores. And as again, you can see, this is the line with the gray boxes is placebo, not much improvement. With cariprazine 3 mg, these filled triangles, if you look at, and with aripiprazole 10 mg and with cariprazine 6 mg, almost equal improvement. So it's as effective as cariprazine. But after week 6, week 5, you can see the improvement with cariprazine much better 6 mg compared to 10 mg of ariprazole. So the ariprazole effect went down a little bit according to the chart. So PAN assessed total score changed, and it showed signal better favored for, I should say, all the 3 drugs, but more for 6 mg of cariprazine. And similarly for CGI-S score, all the 3, the medical arms, the medicine arms, were better compared to the placebo. Also, they have again, as I mentioned, it has been tried in acute mania bipolar 1, and theoretically, in this study, by the Sachs et al., they found that cariprazine was better compared to placebo in reducing the YMRS scores for mania over a period of 21 days, 3 weeks. So in summary, it's a less sedative drug, less EPS, no change in QT interval, less indicative of hyperlactinemia. Anxiety is less compared to ariprazole, because I forgot to mention that with akathisia, sometimes some patients with ariprazole have akathisia. It doesn't have akathisia much with this drug. No changes in weight, better metabolic safety profile compared to other antipsychotics, and it prevents relapses. Thank you so much.
Thank you, Doctor.
Thank
Thank
you,
you, Doctor. Yes. I think the method of your explanation always makes things simpler, sir. And similarly, during this presentation, it made many things clear about cariprazine, which we had forgotten or not paid much attention to. So cariprazine is, I believe, the molecule very similar to aripiprazole. Both are dopamine partial agonist. But I would fire the first question myself. How do you compare the two in clinical real world scenario? I know we have more experience with aripiprazole, so our confidence in that molecule is much more as compared to cariprazine.
Yes.
So where does cariprazine come in the picture?
So theoretically, it's a very good drug for negative symptoms, even better than aripiprazole. But again, because we have used much more ariprazole, we are much more confident, as you're saying. But I think the key lies in using this drug in many more types of patients. So the more you use these patients, because I think in psychiatry, people get very excited with the first few weeks or get disappointed with the first few weeks of the medication.
Yes.
But for diseases like bipolar and schizophrenia, you need to give medicine for months together before you realize the real benefit of the drugs. And I think that
Yes.
we'll only know if you give somebody 3 to 6 months, the patient doesn't relapse, you see improvement in concentration, you see improvement in functioning. Theoretically, very good drug, better than aripiprazole also, theoretically. Again, that's why I kept reporting there, because and in practical does not go together. If you need to have many trials also with this drug, but I've used it in many patients of depression as an adjunct. Depression and schizophrenia. It is not magic also, but it is not disappointing. So this is where I am thinking of this. So it's not that I've stopped using this drug, I'm still using it. Still trying to understand which patient profile exactly works for these patients, for this drug. So what is the maximum dose of cariprazine any patients? Dr. Manu, I think your video froze. So what is the maximum dose? 6 mg is the maximum dose as of the FDA approval. And how can you differentiate the any aripiprazole, as I was mentioning, some patients can have akathisia. Don't have cognitive symptoms of schizophrenia, which aripiprazole doesn't. It doesn't work on D3.
Sir, I think your voice is getting little break.
I think that is one important thing to remember. Okay, let internet connection. Let me.
Hello. Yeah, yes, I'm sorry.
Yeah,
In
you
the
are.
meeting.
Is it better now? Nilesh, is it okay now? My audio?
Yes.
So your voice is still breaking up in between.
Okay. Let me
Mine
switch off my video. Let me switch off my video. Is this okay now? I think this should
Yes,
be.
that would have. Now it's better.
Okay.
Yes,
Audio
sir.
is better.
So
Yes,
I was
yes.
saying that with the aripiprazole, with the cariprazine, theoretically there's a better chance of improving cognition in patients with schizophrenia, and so it may be also effective in patients of bipolar depression, because bipolar also patients can have cognitive side effects, cognitive residue, cognitive effects over a long term. So that way, so that's where it is different from aripiprazole theoretically, because of the D3 and the way it works on the dope and the serotonergic receptors. It does not just work on one; it works on 4, 5 serotonergic receptors, and I think 567 is with the cognition. So if I remember correctly, so I think theoretically it's a good drug to try on patients who have residual symptoms of schizophrenia, residual symptoms of bipolar. They're okay. They're not manic or depressed, but patients are not motivated to do anything. Anhedonia is there, or some concentration issue is there. Try this drug. It should be able to work. Similarly for negative symptoms of schizophrenia. So this is where you should try.
Mhm. Okay. What? Hello, am I audible?
Yes, you are.
Yes, sir.
Yeah.
Okay.
Yeah.
Okay. So we have heard similar promises about cognitive improvement with vortioxetine. If we can go back a little bit, if we can
Yeah.
go back in the cycle, and it did not translate into real world benefits. We have attended and spoken on various forums about vortioxetine. I see similar promise made for cariprazine with the improvement in cognition. And how does it translate to patient benefit? And does the patient perceives the cognitive improvement? I'm not sure about that. But let's come to the question that's asked by the audience. And the first question is, what is the maximum dosage for cariprazine in any symptoms?
So I already, when you were off, I already answered that 6 mg is
Yes.
6 mg is for, so 3 to 6 mg is the dose recommended, both for schizophrenia and for bipolar is 3 to 4.5 mg, and for as an adjunct treatment in unipolar depression up to 3 mg.
Yeah, it's lower dose for depressive symptoms.
Yeah.
Because at higher dose, we need D2 antagonism, right? So
Yes, I think at a higher dose will lead to higher D2 antagonism, and that is the worry.
right.
I initially, when we discussed the drug a year ago, I also recommend. I thought this drug may have an effect, like how for me aripiprazole 2 mg also works. So I think now it has come in the market. I think we need a 0.75 of this drug for Indian patients, because Indian patients का जो profile है वो Western patients से अलग है. So let me give you example of aripiprazole. They would say 20 to 30 milligrams of aripiprazole. Very few doctors write 20 to 30 milligram or higher doses of aripiprazole. Quetiapine, they say 700 to 900 or 1000 milligram. I don't see anybody writing that much of quetiapine, such higher doses. Similarly, for
I think you
mm,
spoke about
for-
Bupron DX, bupropion dextromethorphan combination in our
yeah,
last
that's it.
meeting.
Yeah, yeah,
I still
yes.
remember that you have, and I agree with that idea that uh, the pharmacokinetics and dynamics differ in Indian patients for any drug. Yes.
Yes, yes. Because of our Caucasian bodies are different than the South Asian bodies. I think this is why it is. And so even for amisulpiride also, they would recommend 800 milligram. Nobody's writing 800 milligram, or very few people writing 800 milligram. So lower doses work better for Indian patients mostly. So we probably need, and for depression. So I was coming to depression. I think in depression maybe lower doses of cariprazine may work, which we don't have because it's a capsule form. ना उसको तोड़ भी नहीं सकते. That's what it is. That's the problem with the drug.
Right. So the problem that I see with the institution of cariprazine when I institute this therapy in any patient is the question of tolerability, which is, I believe, lower with the aripiprazole. The initial patient acceptability is a bit different with cariprazine as compared to aripiprazole. What has been your experience at whether the patients, what are the common side effects that you see when you start this cariprazine molecule?
So theoretically, so again, like with any antipsychotics, sedation, uh, uh, akathisia, and sleep disturbances when sometimes that can
Yes.
happen with patients.
Yes.
But with cariprazine, I have not found, except initially, one patient had akathisia, and I also raised that in one of the early meetings. But otherwise, I have not found any much problem with this medicine. And uska reason भी ये है कि I start from 1.5 and I don't hike up in a hurry. I slowly hike up. It takes at least a week or 2 weeks for medicine to settle, and then I hike up the medicine. No hurry to, start it, because this is, because till you understand a drug much more, and still, and for my way of practicing, I
Yeah.
start with the lower doses only. So that's where you avoid. I think the question भी किसी ने पूछा है, how to avoid akathisia. The best way to avoid akathisia is to start. Like I saw somebody starting. I still remember when I was in Vinhance. उस बात को भी बहुत साल हो गए. Somebody coming to me, uh, starting dose of aripiprazole was 10 mg TDS given in manic patient. The patient was restless, and that restlessness was not manic but akathisia, severe akathisia because of the medicine. Better to start with the lower doses of medicine. This is my advice to younger people listening.
Like myself. But yes,
Yeah.
maybe the aripiprazole molecule that you saw being prescribed TDS, that was not made by Heteropharma. So we are not sure about the quality and what is the bioavailability of that. Because this is a very common observation. I also believe that you have also seen that sometimes there are supratherapeutic doses of antipsychotics and antidepressants being written, but what we expect the side effects profile to be there, the patient actually does not have any effect, and neither does he have any side effects. So the quality of
That's true.
the molecule and the API that is being used for manufacturing that makes a lot of difference actually. And I'm new to this Heteropharma, but what I have spoken with other colleagues in other specialties, Heteropharma is known for its quality. So we also expect Heteropharma to bring that quality to CNS and psychiatry, certainly.
No, so this is a wonderful point you brought in, sir, and gives me an opportunity to speak on this. So basically, sir, the core strength of the hetero has been, with the R&D and API to start with. And, one of the, we are one of been the, top API companies.
Yes.
And have been not only into these basic formulations, but as we said, we spoke about biosimilars. So in times to come, sir, you will see more innovative drugs and formulations also, in times to come. So in terms of API and drug qualities, you would see Hetero providing one of the best ones.
Yes.
So, sorry, so I think I got disconnected. I was saying,
Mm.
I think so. There are multiple factors here. One definitely is the quality of the medicine. Second, there are all kinds of patients. So it's not that I have not used higher doses. And some patients, if you look at my prescription, you'll be scared looking at the number of medicines I've written, because some patients are high metabolizers and nothing seems to work for them. So you end up going to 12 to 16 milligram of risperidone, which I will never write, but I had to write for a couple of patients. Olanzapine 30 milligram, 40 milligram. So this can happen with certain patients. But yes, your point is well taken. Depending on quality is also important. But again, for me, for the dictum, for my dictum is to start slow and then go up. Until this patient is very violent and aggressive, then maybe high dose of benzodiazepines or maybe drugs you are much more comfortable with, like olanzapine or quetiapine. You can give higher doses initially. But for newer drugs, start slow, because what happens is you write a drug with a lot of enthusiasm initially, newer drug, the side effects happen, then you rebound and say, okay, मैं तो use ही नहीं करूँगा इस drug को. And that's why you see all those drugs which you have not used. Asinapin, iloperidone, ziprasidone, where are they? They are also good drugs. Word में तो use हो ही रही है कहीं ना कहीं. That means they're not useless drug. They didn't get FDA approval, but we don't use them. We somehow lost. And also the older drugs are also not bad. We don't use loxapine anymore. We don't use chlorpromazine anymore. So those are also, it's important as psychiatrists for us to remember that we have a big armamentarium, but we need to be very careful and learn to how to use different drugs and where.
Yes, because see, psychiatry and neuroscience itself is a very cumulative kind of a branch. And the field is very cumulative. The knowledge gets accumulated over a period of time. And so any new molecule, it has to be significantly better than the established ones to replace it from the market, right? For example, escitalopram, number of antidepressants have come and gone, and we do not even hear about them. But nobody has been able to displace escitalopram from its primary position, right?
Yes.
So it has more to do with the nature of our practice. I don't see any other questions in
One
the
last.
chat box.
One last question has come. In organic psychosis, can cariprazine be
Cariprazine.
suitable?
Who is Mr. Maheshwari? Can we have you on camera, please?
No, Maheshwari guy, their guy. He's writing the questions
He's
from
collating the queries and sharing with us.
because we are live
Okay.
stream.
So it's
we are
a
live
yeah,
stream.
different format, right?
These are
Sir, he's
questions
a
from
IT
YouTube.
person.
Yeah, these are questions from YouTube coming to us.
Okay.
It's not the same person asking too many questions. Okay, so I have not used cariprazine in organic psychosis, but अब वो term organic psychosis भी अपने आप में obsolete सी हो रही है. What is organic is, what is not organic is. So maybe if you're saying, let's say in delirium, can you use this drug? Yes, why not try it out? Well, you should. We can try it out. Definitely. It cannot be, so it can be given in pregnancy? No, as of now, no, because we don't have enough evidence. First, try and use in our population, see, because what will happen is when you use a drug for many years now, you'll end up seeing some case reports of this drug by mistake. Patient, they took around the pregnancy and nothing happened. Then you say, okay, this is safe in pregnancy. Or somebody would have to try and they said, okay, this is fine. Any serious side effects you use trixapenide along with cariprazine? No, I don't see why it should be. Not that I'm aware of. Can it be given in geriatric patients? Yes, you can give in geriatric patients. Again, the dictum is start low and go slow. That's the dictum you remember. So you give only 1.25, 1.5 mg, sorry. And similarly for dementia-related psychosis or organic psychosis or geriatric patients, you can start with 1.5 mg. You see what happens with geriatric patients is, especially patients above 75 and above, you give 1.5 mg, family says कि कुछ नहीं हो रहा डॉक्टर साहब, ठीक नहीं हो रहा, and they pressurize you, you go up to 1. You do double the dose, not just for this but any drug. And you see after 3-4 days, patients become very sedated because of the way the body metabolizes the drug. The body does not metabolize the drug fast, so body gets accumulated. The drug gets accumulated over time. So you have to be very careful with elderly patients. So this is my advice to all of the youngsters. And in comparison with ariprazole, the trials I showed you was with ariprazole. It is as effective as aripiprazole, and I use this drug on a BD dose, just like that, but it's actually you can use it OD, no problem. Because when you have 1.5 mg, sometimes which is not available, you give twice a day. That's the only thing. I've not found any method. Yeah.
Yes, please go ahead. Please finish whatever you say.
I'm trying to fast finish the question because we have 9 o'clock already.
Okay.
Any metabolic changes with cariprazine? I've not found any patient gaining weight or having any prolactin issues with this drug as of now. एक साल तो हो गया. So this question I've already answered. And so any organic psychosis, yes, it is. We can try it out. I've not tried it, but you can try it out.
Yeah. So I'd like to add what you were saying and add some evidence to it. The results from evidences that we have for cariprazine. I believe cariprazine can be used off-label wherever trials for aripiprazole are available. It's quite a similar drug with a similar side effect profile. So if you want to use it off-label for any indication, please go through trials of aripiprazole. And wherever it has been found to be positive, I believe cariprazine can also be instituted in the same. I found one single trial where cariprazine was compared to risperidone for the effect on negative symptoms in schizophrenia. And this was one trial where cariprazine scored significantly better than risperidone, which is an established drug, and we have much confidence in risperidone for use in schizophrenia. So there is a single trial, head-to-head trial. Otherwise, I could not find any trial where there was a head-to-head comparison. Of course, comparison placebos were there, and but none head-to-head trial. So negative symptoms, I believe it holds a lot of promise because we have very few promising agents apart from aripiprazole, amisulpride. So cariprazine can be one molecule that can be in our armamentarium to use in negative symptoms. Right. And yeah. So any last observations by Dr. Vishal?
Nothing. My request or my suggestion to everyone watching this is that please read more about this drug. Use it in as many patients as possible in the indications it indicated. That is mainly schizophrenia, bipolar, and also as an adjunctive for unipolar depression. Try it out. You can try it in elderly patients with psychosis. See if this is because it is not very sedative drug. Doesn't have metabolic side effect. Maybe it's useful there. Try it out there also, and build your own understanding of this drug. And when we meet again in some other forum, let's discuss again. Thank you.
Like to share one more nugget, sir. We have undertaken a trial comparing risperidone with cariprazine in schizophrenia. So that trial is undergoing. It is a registered CTRI trial and a non-funded trial, totally out of our own pockets. We are conducting it at BMMC in Safdarjung Hospital. Me, Dr. Shelly Meena, the two faculty members are carrying out this trial. We have finished recruiting the patients, but one observation from the trial that I'd like to share, it's not confirmed. We haven't compared it statistically, but yes, we had many patients who were not able to tolerate cariprazine at a higher dose because the dose we used was above 4.5 mg in schizophrenia. So we had to change those patients because ethically it's not permissible to carry on with the trial, and the patients themselves requested to change them to another medicine. So there were certain instances where we switched from cariprazine to other molecules, but we'll publish that the results of that trial very soon. The recruitment is complete. So we recruited 100 patients each. We randomized those patients RCT.
Very nice. Very nice. That's very good. That's very good. Very, very good. बहुत अच्छा लगा सुन के. That is, we are doing a trial on your own and not through funded. So this is good. बहुत अच्छी बात. That's good.
Thank you. So
No, sir, I think
part of the-
the questions, all the questions and the queries have been addressed, and later, whatever comes, we'll put it across, and we would like to, have many such forums and, take these things forward. So, with this, sir, on behalf of Hetero Healthcare, I, with all my exceedingly gratitude, extend my hearty, vote of thanks to Dr. Vishal Chandra and to Dr. Manushree Gupta, for sparing their valuable time, out of their busy schedules for this webinar, and which actually I feel had been very, very informative. Uh, Sir, today, it was a good opportunity to hear from you about your thoughts on, Cariprazine, as the novel drug, for management of bipolar uh, disorder, schizophrenia, and even particularly, sir, for unipolar depression, which you shared, had been very, very informative, and it gives us a lot of insight, how to manage these such disorders. And once again, sir, I really extend my gratitude and thanks for taking time out. And I would be requesting Dr. Vishal and Dr. Manushree that if they can support us with many more such educative and informative webinars. Right, sir. But thank you so much, sir, for taking your time out and giving us your valuable clinical insights on Cariprazine.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, Vishal
Thank you
sir.
so much.
Thank you, Manushree sir.
Thank you. Thank
Thank
you.
you. Thank you. Thanks.
Thanks, sir. Good night, Dr. Vishal.
Good night. Good night, Manu.
Good
Thank
night,
you.
sir.
Thanks, sir.
Thank you, team.
Thank you.
Bye.
Thanks.